So next, we'll go ahead with the panel discussion. And in the panel discussion, we have Dr. Rachna, Consultant Medical Oncologist and Associate Assistant Professor at Medical Oncology at Nizams. Dr. Rachna, are you there?
Yes, sir, I'm there.
Next, we have Dr. Bala Stalin Chaudhary, again an Associate Professor, Assistant Professor at the Department of Medical Oncology at the NIMS, Hyderabad. Dr. Bala,
yes, sir,
I'm
there. I'm there.
Okay. Dr. Rekha Bansal, Consultant Medical Oncologist in Apollo Hospital.
Yes, sir.
Dr. Rekha, you're there? Okay.
Yes, I'm here, sir.
Dr. Saju SV, Consultant in the Department of Medical Oncology, Hemato-Oncology, Pediatric Oncology in BMT at the Meenakshi Mission Hospital in Tamil Nadu. Dr. Saju, are you there?
Yes, sir, I'm here.
Yeah, hi. Next, Dr. Biswajit is there. He said he might not be able to join. He had some urgent thing coming up. Yeah,
no, sir, he is not joined.
He is not joined. That's fine. Dr. Vinayak Maka is a HOD and Senior Consultant, Medical Oncologist and BMT Physician at the MS Ramaya Hospital at Bangalore. Dr. Vinayak, are you there?
Yes, Vamshi, I'm there.
Yeah, great. So what I'll do is we are running a little late. I will not take too much time. In the next 20 minutes or so, we'll just talk a little bit about sequencing agents for HR positive in clinical practice. Now, I'm not going to go into the depths of each trial because frankly, we have been doing that for a long time. And this is possibly, I don't know which number of, moderation or discussion we have been having on the CDK4 inhibitors since the last few years. So next slide, please. I'll just start off with a simple case, a 74-year-old lady who basically came with only back pain. Evaluated by an orthopedician, only analgesics were given, then MRI spine was done, which showed multiple lesions in the spine. So after that patient was referred to us, where on questioning, she actually admitted to having a lump in the breast, which was around 4 into 3 centimeter in size. Biopsy was done, came as an infiltrating ductal carcinoma, ER/PR positive, HER2/neu negative. Next slide, please. So this is the image. Now, as you can see, the breast lesion is quite large, multiple few mediastinal nodes, multiple bone lesions. You know, entire spine is almost studded with lesions, and a couple of liver lesions as well. So next slide. So for me, the most important thing to begin with, Dr. Rachna, do you look at this as a visceral crisis, as a visceral disease? Are those terms that are still in use? Are we looking at a visceral disease or a visceral crisis?
Yes, sir. Visceral crisis, yes, we need to look for every ER/PR positive metastatic breast cancer. And that, as we all know, the definitions, the deranged LFTs or presence of lymphangitis carcinomatosis, patient is symptomatic for lung metastasis, those we have to consider because we need to give them chemotherapy. And coming to visceral disease, if we are speaking about the CDK4/6 inhibitors, yes, there is some slight difference being shown between palbociclib and ribociclib and abemaciclib, with palbase being slightly effective in the bone-only disease. Yeah. Okay.
We'll come to those differences. So, no, the reason why I'm asking Dr. Stalin, if you can take this question, saying, is this concept of a visceral crisis, has it evolved over the past few years? I mean, are we 5 years back or 10 years back, anything with disease not in the bone would qualify automatically for chemotherapy? Are we still looking at that scenario or has it changed? So I just wanted opinion of the house on that. Dr. Stalin, and then maybe Dr. Rachna can take it again.
Yeah, it has changed a bit with the advent of the CDK46 inhibitors. So possibly previously all the disease which is there in the visceral disease, patients we tend to treat more with chemotherapy, and bone only disease most probably we treated with endocrine therapy. So with the advent of CDK46 inhibitor, so possibly we will be using chemotherapy only for the patients who are breathless or who have a deranged LFT. So we have significant organ dysfunction rather than mere presence of metastasis in the visceral organs.
So, Dr. Rachna, considering this definition of altered LFT, again, are we now stretching the definition a bit that, looking at reasonably good PS, just having altered LFT, would you still go for a chemo? Or is it something to do more with the performance status? Or how do you decide what is a visceral crisis?
It's more depends on the performance status and the disease burden, sir. Not just the LFT, because if we consider a mild derangement of more than 1.5 times the upper limit of normal, we may not directly go ahead with the chemotherapy. And we also were a part of the Right Choice trial, which was looking at the patients with visceral crisis on CDK4/6 inhibitors. We are awaiting the results. So maybe
Okay.
that will better help us.
Wow, that will be really useful. Dr. Rekha, in your practice now, in how many actually cases of visceral crisis are we seeing? Again, considering all the disease that we see, what would be the percentage where you would say this is a visceral crisis?
Less than 5%, I would say, sir. I mean,
Less than
most
5%.
of the, yeah.
Yeah, Dr. Saju, do you agree with this? I mean, it's less than 5%. Is it as much as it used to be?
In our clinical practice, it is little bit on the higher side, probably around 10 to 15%.
10 to 15%. So again, it's interesting that, even though you're saying it's in your clinical practice and still it's only 10 to 15, that's something which is, I think, heartening. Maybe the patients are coming earlier, but at least personally, the confidence we have in using CDK46 and endocrine therapy for a visceral disease is, I think, quite robust now. We don't automatically jump the gun. In fact, I try to look actively for a place where I will avoid chemotherapy. And I don't know where we would have last used. Dr. Vinayak, last 100 patients, how many have you actually used chemotherapy in metastatic breast cancer? HR positive, of course.
Not defined by a visual crisis, but definitely I used 30% of patients with
30%.
chemotherapy.
Okay.
Yeah, but one thing is there, which I think this patient is differing, is the de novo it is there. For de novo, I have not used much of patients with chemotherapy.
I'm sorry, Dr. Vinayak, I think I lost you.
Yeah, de novo patients, like for the patient present, like this patient, she is of upfront metastatic disease. I would try some hormone therapy before I go for.
Okay. But you would not go for chemo at least. I think that's the point which I'm trying to get. Will you use chemo?
Yeah, I would not go. I'm not gone in any chemotherapy for any patients who are upfront metastatic disease, hormone positive. I have not seen any visual crisis of late, but definitely.
Perfect. I think that's the point we are getting. A group of medical oncologists, all of whom are saying, let's not give chemo and let's try something else. That's the real paradigm change that has happened in the past 5 years. Next slide, please. So again, now this is what we were discussing, and I think this has been answered by everybody. You would go with an AI with a CDK4 inhibitor, I guess. Regarding the AI alone, fulvestrant alone, I don't want to get too much into detail, but just Dr. Krihsna, just if you can say, is there any patient, logistics and affordability aside, where you're comfortable with using only an AI or only a fulvestrant, or would you be comfortable using CDK46 everywhere in combination?
I would be comfortable using CDK46 combination, sir.
Perfect. So, Dr. Stalin, any patient where you would like to use, again, I'm just stretching the boundaries of our clinical practice and asking you, this is not a, hard and fast thing.
Sir, majority of the times, in fact, 100% of the times, my choice is AA plus CDK46, and I will reserve the fulvestrant in the second line.
I kind of agree with that. I think the only off cases are those rare incidents where you have a patient relapsing with a single bone met, which you would treat as an oligometastatic and things like that. But otherwise, any patient with a metastatic, frankly, metastatic breast cancer, I think all of us are now comfortable with using a CDK46 plus a AI in the first line. So next slide, please. So one thing is, this is regarding the decision of therapy of using CDK46. Would anything like the age or the performance status or the comorbids, would they play any role? Dr. Rekha, would that matter to you before you give any chemotherapy?
No, sir, certainly. So, I mean, none of them matter because I think CDK46 inhibitors are pretty much tolerable. So, I guess we're not talking about which CDK46 inhibitor, but
that's next. Yeah.
So, age no bar, PS no bar. I think we do have something for everyone. So, yeah.
Fantastic. So, what's the oldest patient you have given CDK46?
80-year-old, sir.
80. Okay.
Unfortunately, I lost her within 2 months due to other reasons. But yeah.
That's sad. But yeah, 80 years. Okay. Dr. Stalin, your record?
Possibly 80 years. 80, sir.
80. Okay. So, Dr. Saju?
65, I think.
65. Okay. You're still back in the race. You need to get the elderly people, I think, in more. Dr. Vinayak?
Yeah, 82.
82. So I think I'm the winner. I have an 84-year-old on CDK46 inhibitor, which she's tolerating quite well. It's been a year now since she's on the medicine. And from someone who came in a wheelchair, now completely walking on her own and doing her own work. So that's really the great thing about doing CDK46. Dr. Vinayak, any comorbids that you're worried about when you treat? I mean, is there some comorbid that will preclude use of any CDK46 inhibitor?
So QTC interval for ribociclib.
Yeah, but then you can use the
pre-existing
other
GI.
drugs. Yeah.
Yeah, so not all CDK inhibitors, but for GI symptoms, already GI existing symptoms, I would avoid abemaciclib. And Palbase, I've been using it. That's it.
Yeah, I think that's the fair enough thing, and for all of us, it's the same. I think wherever this, you will always find some CDK46 to fit some patient. I think that's the bottom line that I was going for. Next slide, please. Next slide. So again, we have discussed about the chemotherapy. Next slide. And coming to MBC in HER2 positive, is there still something that you would say are poor prognostic or something where you expect less? You know, I've just given a list of liver lesion, PR negative, CNS. Are these really important, or is it something that we would probably not really decide on it? So, Dr. Saju?
Yes, sir. Actually, these all parameters are important. If the patient is presenting with bone-only disease, probably that is the best prognostic group. If the patient's having extensive liver mets, PR negativity, and with presence of CNS disease, they are going to perform bad with CDK46 inhibitors. And in the scenario of primary endocrine resistance, also probably I would consider chemotherapy rather than this endocrine therapy.
Okay, that's an interesting thing. We'll come to the endocrine therapy. So, Dr. Saju, you can take the $1 million question. I think that is basically what we will be discussing in the next 5 minutes. How do you decide which CDK4 to use? We have 3. How do you decide which one to use?
As of now, I have used only palbociclib and ribociclib. Abemaciclib I have not used. It was purely based upon the financial background of the patients, not based upon any comorbid status or anything. Okay,
but given a choice, you have a patient in front of you who can afford all 3. Because frankly, the cost of all 3 is by and large the same. I mean, with whatever support program, etc., it turns out to be almost the same price for all 3. Given that, how do you decide on your CDK46?
If the patient is having not having any cardiac problem or liver function is normal, then I would prefer ribociclib first. Okay. And if he is having any comorbid issues, then palbociclib would be my first choice.
Okay. Dr. Rachna, you were talking about the preference of the CDK4 earlier. So how do you decide which CDK4 to go for?
So in the clinical practice, it is a financial thing which is guiding us to decide on the.
That's fine. You know, let's not get into finances. Everyone knows what's important. Yeah. But otherwise, patient in front of you with all options available.
Then I would like to look at if the patient is on multiple drugs for other comorbidities, if you're speaking about an elderly female, and then and if these drugs are going to increase the QTC interval, which ribociclib is also going to affect, I would consider going for a palbociclib. Other than these minor things, there is no hard and fast rule that this is the CDK4/6 I would be using.
Okay. Dr. Vinayak, I have put this later in the course, but I'm just a bit curious. You know, we have now data from phase 3 trials, 3 phase 3 trials in the first line, one of which has not given us any overall survival benefit. One has given a definite OS benefit. One, it is pending with an interim study showing OS benefit. So if you don't have an OS benefit, would you still consider using palbociclib? Dr. Vinayak, you're on mute.
I would prefer to use Palbase. The main reason for Palbase usage is the tolerability for me.
Okay.
PFS benefit is good enough. In a metastatic disease, we can get only PFS as of now.
You have OS benefit in the other drug.
I know that part.
That's why I'm asking you. I'm just curious to know what people are thinking.
I have been now using more of ribociclib than compared to Palbase.
Okay.
We had a study for albaciclib when the trial was running with us. We had recruited almost close to 13 patients. The experience was not great in the trial setting itself.
Okay.
So, answer.
Okay. No, fair enough. It's just a experience. Dr. Rekha, how do you decide on the CDK46?
So, sir, before the OS benefit data from Mona Lisa, I was thinking
Okay, I think we lost her right now.
Hello, am I audible,
yeah,
sir?
now you're audible. Yes.
Yeah, so I was saying I think the 3 CDK4/6 inhibitors are after all different, and OS benefit definitely changes my decision. I would prefer ribociclib over palbociclib, and regarding the use of abemaciclib, maybe certain subsets, but then we do have data for ribociclib even in CNS metastasis, even in PR negative. So I would say the 3 CDK4/6 inhibitors are after all different, probably.
Okay, interesting. So, Dr. Stalin, do you agree 3 CDK4/6 are somewhat different is what Dr. Rekha says? Do you agree with that, or how do you decide? Again, finances aside.
Yeah, definitely, sir. So keeping finances aside, if you give me an option, definitely with the current available phase 3 data, I will be choosing ribociclib over other two because of the robust OS data it had compared to other two as of now, pending the final OS data of abemaciclib. So, but majority of my experience is with palbociclib.
Okay. Again, I think Palbo has been the first mover, so all of us are either comfortable with using Palbo, and that's one of the reasons why we seem to use it so much. So, Dr. Saju, do you agree with this? When you go into the trial depth, the EBIMA says that we have substratified the liver lesions, we have substratified the PR negative, and we have found benefit in that. There is a group which has shown CNS disease and is positive. Now, Ribo has come up with post hoc data and subset analysis again in the same subgroups. Dr. Satya showed us very nicely in the complement trial that CNS disease was included and everything seems to benefit. So do you think it matters that the trial included it upfront, or that you're getting post-op analysis and it's good enough? What do you think?
CNS disease, we have evidence for both Ribo and Abema.
Exactly, yeah.
Yeah, but otherwise, these substratifications are clinically not relevant as far as my personal view.
Okay. Okay. What do you think about this OS data with the Paloma, which really did not come? Now, numerically superior. Remember, it was numerically superior, just not the statistic significance. Now, in a different context, somebody just discussed with us and said, look, as long as I'm getting a PFS, I'm happy. It really does not matter the OS for me. Do you agree with that? Or do you think when you have one drug which is giving you OS anyway, why not use that? Why stick to one drug? What do you think about that?
Yeah, I mean, if the drug is giving a very good OS difference that statistically significant, then I would choose that drug. But practically speaking, it's like dasatinib, nilotinib, and bosutinib in CML. Whichever.
Okay, I think Dr. Stalin might have something to say to that. He had a very impassioned issue with dasatinib recently. But anyway, next slide, please. So again, I think the key takeaway from everybody in the panel does seem to be that yes, there is some difference between the two. However, at some level, you may probably not read too much into the trial. As long as you're getting a good PFS advantage, you seem to be okay. And the tolerability and quality of life also seem to be more important for deciding which drug to give. So I think that's a very practical and normal aspect of how we actually treat in the clinics. Next slide. So these are the major trials that I have shown. Again, I'm not going into too much depth here. I think everyone is very well aware of the trials. Next slide. Next slide. This is the PFS advantage. Again, more or less similar for all the trials. And I'm not sure a couple of months extra in a cross trial comparison really matters. Next slide. Next slide. Next slide. So the last two questions is the one which I can you go back one slide, please? So last two questions are something which I was really wanting to discuss with everybody. Dr. Krihsna, you can start. Do you think this different CDKs are interchangeable? Number one, somebody is on Ribo and they come to you, want to change it to Palbo, something like that. Would you ever do that? And secondly, monotherapy with CDK4/6. Again, not too much data on this. I'm just asking, do you think it is an option? Because the EBIMA people say that, yes, we have a monotherapy data. Is that at all any meaning for you?
So coming to the interchangeability, if the patient is recently started, I would say like 15 days or a month of one CDK4/6 inhibitor and not tolerating or developing a febrile neutropenia with palbociclib, yes, I would consider changing it. But if it is a longer course of therapy, I wouldn't plan to change the CDK4/6 inhibitor. And monotherapy, maybe in the third line setting, but not in the upfront or the second line setting. Based on that,
that's perfect. I think that's kind of what the data says. Dr. Vinayak, I'll ask you the most difficult, or rather the most controversial question. We might be getting some kind of a generic sooner or later. what then? Would you be happy to interchange when patient comes and asks you? Because costing is going to be different.
I have not changed till date any CDK
Okay.
inhibitor. That's because I have not used abemaciclib so much.
Okay.
But even generic is there. I think you must be knowing Palbis is available free of cost for BPL patients. So I don't see economical concerns will address that.
Okay, perfect. I think that's a very valid point. For those who really had problems, anyway, we're getting it free, so that will not really change what we are going to be doing. And that will continue to maintain whatever ribo and abema we were giving. I think that's a very valid point what you're making. Next slide. So regarding the hormonal partner, I think again, this is a question which has been done to death. I think by and large, everyone is comfortable with an AI. If it progresses on an AI, probably that's when we use a fulvestrant. Next slide. Next slide. So again, we have talked about the OS data and the importance of the real world evidence. Next slide. So just one or two more points we can discuss. Dr. Stalin, would you test PIK3 upfront or do you test it later?
So majority of the times we are testing it at progression, not doing upfront.
Okay, and do you do liquid or do you do solid or do you do a sequential like what Dr. Charu
sequential,
was saying?
sir. It is majority of the times it is sequential. First do a liquid. If it is negative, then a biopsy.
I think that's by and large what all of us are doing. I think these are all issues that have been kind of addressed over the past 2 years. There have been a series of pandemic-induced webinars where we have been hammered with all these points, and I think by now all medical oncologists are aware of these things. Whether we do it in practice, sometimes we may not be doing it because of various reasons, and if a patient can't afford alpelisib, doing this test may not really make much difference, honestly speaking. But at least we are all aware of what to do. Next slide. Second line, when I'm talking about, I'm just talking of endocrine resistance. And again, very interesting comment Dr. Saju made that if it's an endocrine resistant, he would probably still give some form of chemotherapy first rather than just going for a CDK46. Dr. Rekha, would you do? Would you still, primary endocrine resistance? There is data from ribo as well as data from abema. Would you go with that, or would you still prefer maybe some sort of chemo?
Primary endocrine resistance, I would try abema, sir. So if the patient has not progressed on CDK4, definitely I would use CDK46 inhibitor, sir.
Okay, so I'm talking about endocrine resistance. So basically patient progressing in the first adjuvant, something like that. Okay, fair enough. Next slide. So just one more point that I would be talking about, next slide. I think these all are things you have pretty much covered. Just the previous slide, please. So the last thing which I'll be talking about is this new trial that has come, the MAINTAIN trial, on the benefit of continuing CDK46 inhibitor at progression. So Dr. Stalin, what do you think of that MAINTAIN trial? It is a phase 2 study maintaining the ribociclib while changing the hormonal treatment. Is this a valid option, or would you just prefer changing to the next line?
Possibly a valid option, sir. If the patient is a PIK3 non-mutant and not, so then changing the endocrine therapy and continuing the CDK46 is a valid option. But this is just a phase 2 trial. But in the real world, definitely we can continue if the patient is affordable for it, especially if the patient is PIK3 non-mutant.
Perfect. Dr. Vinayak, your thoughts on this?
Yeah, I've been doing that. The thing is, Palbis is free after some time, and most of the ribociclib is free after some cycles. At progression, I have changed the hormonal therapy instead of changing the whole line. And I have seen the responses after changing the hormone therapy. So I'm okay to maintain this data is phase 2, but our personal experience is being good.
I agree with you, and I think more importantly also is the degree of change. You have only a few extra mets, only few extra bone mets, non-symptomatic, no real visceral crisis or visceral disease. You're probably okay to just continue the CDK4 and maybe just change the hormone. That's the other thing we need to look into, the degree of progression. So I think with that, I'll probably close my talk, because we can discuss other things, but these are again topics that have been discussed and we are running a bit short of time. So if there's anything else which the panel wants to ask, there's one question which has come around. Dr. Stalin, if you can take this. So are all patients affording these targeted, or you try only in those who can afford, and how do you manage the patients who cannot afford CDK46? So it's a practical question that has been asked. So Dr. Stalin, if you can take that.
It's most relevant to my clinical practice also, sir. Majority of the patients who don't afford, but till now we managed with the patient support program of the Palbis, and So many patients of metastatic, de novo metastatic ER positive are receiving the CDK4/6 inhibitor. I don't think with the patient support program, it is not that difficult thing.
Okay, fantastic. So thank you, everyone. I think that's a very nice panel. Again, I think these are topics where a lot of clarity is emerging on how we are going to treat. And most of our patients now, I think we are pretty clear on what we are going to be doing. Of course, as the data evolves, we are going to change our treatment and tailor our treatment and start looking at importance of sequencing. So,
Sir, can I ask a question?
Absolutely, please.
Sir, any experience with the Tamoxifen along with the CDK4/6 inhibitors?
Okay, Dr. Rachna?
No, sir. I did not use it, sir. Use the combination.
Dr. Vinayak?
Used it in...
Yes,
Dr. Vinayak, just a minute.
Yeah.
So this question arises when you have premenopausal women. Just correct me if I'm wrong. So usually we go for ovarian suppression either by medical thing or by surgical and offer them postmenopausal status and AI. I have not used tamoxifen with CDK inhibitor till date.
Okay, Dr. Stalin, you were saying something.
Yeah, this comes to the point when seeing a male breast cancer also. I think that's a rare thing what we see in clinic, but in males, metastatic majority tend to be ER positive. They are metastatic, so this is a valid option. Tamoxifen plus CDK4/6 inhibitor is a valid option because tamoxifen is the most robustly studied ER targeted agent in male breast cancer.
Yeah, I think, but the ML7 included one of the Mona Lisa studies included males and they used AI in that. But, Dr. Saju.
No, Vamshi, you have to go with along with octreectomy because it is not complete if you give AI without suppression.
Yes, obviously. That's fine.
This is Dr. Meher.
Yes,
if you can permit me, I'll try to answer this question.
Yes, ma'am.
I did start a patient of premenopausal woman with tamoxifen plus AI. I planned to put her on palbociclib, but the support program did not allow to put the patient on tamoxifen. So they bought for a few months. Later on, I had to do the patient had to go for a oophorectomy, and later on I shifted to AI plus CDK4/6.
Okay.
So still, there are studies, and this combination can still be given in premenopausal women.
Oh, Dr. Saju, I hope that answers your question. So, anything else that you were looking for specifically in this?
Actually, in my clinical practice, I have used in few patients. I personally felt it works better than AI in premenopausal.
Okay. I have not used because, like Rachna says, everyone who is premenopausal will be made postmenopausal some way or the other. So I have not used it personally. I feel AI with the postmenopausal is probably a better option, but fair enough. This is something that we can explore. So again, if no other questions, thanks to all the panelists for a great discussion. And if you can just stop sharing the slide, thank you so much. So the last talk of today.
One more question in the chat box.
Okay, just a second. I saw only one question in that. There was one question which we have answered. There's only one question and one more in the chat box. Let me just open that. No, I am not seeing any question, Geetika.
Okay, sir.
Yeah, okay. So the last talk for today will be by Dr. Meher Lakshmi, and she'll be talking about